And how long you work? I think it's already like more than 20, 30 years.
So our practice has been here, not here in this location, but the practice has existed for at least about 40 years. I have been working in this practice for about 18 years, and before the 18 years, I did 6 years of training. So I've been in medicine for more than 20 years, almost 25 years. Oncology specifically, about 21 years.
And how much it changed from that time to now?
It is changing every 6 months. Cancer care has become, and it continues to become very, very, very much more specialized. Before, anyone who had breast cancer or lung cancer or colon cancer, all of the breast cancers were treated the same way. All of the colon were treated the same way. Now, when we get the biopsy or we get the surgical specimen, we look at the genetic makeup of the cancer of that person, and we individualize the treatment, because based on the genes, many times we can predict this medicine is going to work better, this medicine will not work. So the one size fits all doesn't happen anymore. So that is the biggest change that's happened in oncology, and it's only getting more and more and more specialized. I always tell people, just because you have 5 dogs of the same breed that look the same, look exactly the same, their nature and their behavior can be different. One of them can be very aggressive. 4 of them can be very, very timid. So you have to know the individual features of a person's specific cancer to give them the proper treatment. That's how it's changed very much over the last few years.
And how it changed for prognosis? People start to live.
We're able to cure more people. We are doing much more effective methods of screening to find cancer earlier. So yes, people are living longer with cancer. Even stage 4 disease, which is incurable, they're living much longer than they used to live, because we have a lot of different options that help patients maintain their quality of life and extend their length of life. Unfortunately, for the stage 4 patients, most of them we still cannot cure. That's still the biggest challenge in oncology.
And what about patients that are already in last?
So we take pride in treating the patients from the beginning all the way to the end. Sometimes the end is curing the patient. Sometimes the end is you cannot cure the patient and they're going to die of their disease. And if that happens, it's very important to decide at a time with the family, with the patient, that they can have good quality of life and enjoy their loved ones and be given the services that they need. That's known as hospice. So we also follow them during that time of life. So when they're at home, or sometimes they're in a facility because they can't be taken care of home, the hospice nurses will let us know how they're doing, if we need to adjust their medicines, if they need something for pain or for breathing or for anxiety or for nausea. If they cannot be comfortable at home, we have inpatient facilities where they're taken care of 24 hours a day, 7 days a week, with the right medication. So in this day and age, we take a lot of pride in making sure that if someone is passing of cancer, that it is not an uncomfortable and any more traumatic than it needs to be for the family. So they get the right medicines, they get the right equipment at home, and when the patient passes, they get grief counseling, the family. We have social workers that are calling them, that are asking them how they're feeling, and helping them with their grief, talking to them. If they feel they need psychiatric help or medications, they will refer them to the proper doctor. So it's about not only taking care of the patient, but you have to as much take care of the family, because they're going through this journey also.
And if prognosis is not good, do you talk with patient and choose what to do? Because in Russia, normally they say, you have this, we will make surgery, we will make chemotherapy, we will make this, and they don't really ask, don't really give you a
So,
prognosis.
here the thing is the only way that you can truly help a patient is by educating them about their disease, their diagnosis, what it means, what the prognosis is, and how we're going to get them through this journey. The patient has to be an active participant. They must understand. If they don't understand and you just tell them you have to do this and this and this and this, that's going to be a much more difficult process. There's going to be so much more anxiety in the patient if they don't understand. Why am I getting these side effects? Why am I feeling sick? Why am I doing this? Maybe I should stop. So we feel through doing this for as long as we have in the United States, that the proper way to treat cancer is to make sure that you don't just give advice. You have to listen to the patient as much as you talk to the patient. And you have to make sure that the patient and the family understand as much as they can understand. And it's my job to take the complicated medical terms and make it very simple. I told you the analogy of the dogs. That's how you have to talk to them. You have to give them examples of real world life and compare it to that so that they can understand. And when a patient understands and they get it, that journey is much easier. Then they feel like they have control. They feel like they have an understanding. They know what to expect. They know that, okay, my doctor says my cure rate is very high if I do these 4 doses of chemotherapy. So maybe I'll get sick, but I'm going to get through these 4 doses so that 5 years from now and 15 years from now, I never deal with this again. If they know that from the beginning, it's an easier journey. If they don't know, oh, why am I doing this? Am I going to get cured? And they're getting sick. It's going to be very hard for them to continue.
And do some people, if prognosis is bad, choose to do nothing?
Yes. And when you discuss this with the patient, you have to tell them as one choice, and we can do nothing. And sometimes we will say, I recommend we do nothing. If there's an older patient in their 80s, ill, in a wheelchair, heart disease, kidney disease, you know that if you give them the medicine, it is going to shorten their life. They're going to have more side effects. Their quality of life is going to be worse than it is now. So yes, that is always going to be a discussion for those patients who have incurable disease.
Okay. I think it will be last question. I hear that in Europe, in America, for pain, people use medical marijuana.
Yes. So medical marijuana in the United States is a state-by-state decision. So there are many states that have it. There are some states that don't have it. So it's not throughout the country. We use a lot of it because medical marijuana can do 3 or 4 very, very good things for the cancer patient. It can help the mood. It lessens the nausea. It increases the appetite. And it helps with pain. And it helps with sleeping. These are all problems that the cancer patient has. So I use it. I use it a lot for my patients because it gives them help with these symptoms, and it has very little side effects. Yes, it'll make you high. It'll give you a buzz. You cannot drive a car or operate heavy machinery, but it won't have any lingering side effects. We have some medicines that can help with appetite, but one of the medicines that we use, it can cause blood clots, for example. So some of the side effects are terrible. With marijuana, you don't have that. So it has been a huge help for many patients in the oncology realm.
Oh, that's new for me. Thank you. it was very interesting. I think it will be very interesting.
Thank you.
Uh,
Thank you.
our-
Thank you.
Thank you.
I'm glad I could help. Thank you.